Welcome to Uber School's comprehensive review of genetic and developmental pathology for the USMLE Step 1. I'm Pete, and joining me today is my co-host, the one and only Crash. Are you ready to dive into the world of chromosomes and congenital abnormalities, buddy?
You bet, Pete. And let me tell you, I'm more excited about this than a bow hunter on opening day. We've got a lot to cover, so let's get started with chromosomal disorders. Remember, folks, this is an Uber School production designed to make sure every single one of you aces that test.
All right, Crash, let's kick things off with numerical chromosomal abnormalities. These are divided into aneuploidy and polyploidy. Aneuploidy includes trisomies and monosomies. The most common trisomies are trisomy 21, Down syndrome, trisomy 18, Edwards syndrome, and trisomy 13, Pathology syndrome.
Hold up, Pete. Before we dive deeper, let's make sure our listeners understand what these terms mean. Aneuploidy is when there's an abnormal number of chromosomes, not a multiple of the haploid number. Trisomy means 3 copies of a chromosome instead of 2, and monosomy means only 1 copy instead of 2. It's like archery. You want 2 arrows in your quiver, not 1 or 3.
Great analogy, Crash. Now let's focus on Down syndrome, the most common trisomy. It's characterized by intellectual disability, hypotonia, low muscle tone, and distinctive facial features. These include a flat facial profile, upslanting palpebral fissures, and a protruding tongue.
Don't forget about the increased risk of congenital heart defects and early-onset Alzheimer's disease in Down syndrome patients, Pete. Now, how about we hit our listeners with a practice question to keep them on their toes?
Sounds good, Crash. Here's one. A 38-year-old woman gives birth to a child with upslanting palpebral fissures, a flat facial profile, and hypotonia. Karyotype analysis reveals 47 chromosomes. Which of the following is the most likely diagnosis?
All right, future doctors, put on your thinking caps. Is it A, Turner syndrome, B, Klinefelter syndrome, C, Down syndrome, D, Edwards syndrome, or E, Pathology syndrome?
Take a moment to think about it. Remember the characteristics we just discussed? The answer is C, Down syndrome. The description matches the classic features of Down syndrome, and the 47 chromosomes indicate a trisomy.
Bullseye, Pete. Now let's move on to the other trisomies. Edwards syndrome, or trisomy 18, presents with severe developmental delays and congenital heart defects. Pathology syndrome, trisomy 13, is associated with severe intellectual disability and structural brain abnormalities.
Excellent, Crash. It's crucial to remember that these trisomies have poor prognosis. Most affected individuals don't survive past infancy, especially in Edwards and Pathology syndromes. Now let's shift gears to structural chromosomal abnormalities.
The architectural side of genetics. We're talking about deletions, duplications, translocations, and inversions. It's like rearranging the furniture in your genetic living room, but with potentially serious consequences.
That's right, Crash. One important microdeletion syndrome to remember is DiGeorge syndrome, caused by a deletion on chromosome 22q11.2. It leads to cardiac defects, immunodeficiency, and characteristic facial features. Another key one is Prader-Willi syndrome, resulting from a deletion on chromosome 15q11q13.
Prader-Willi is a real doozy, Pete. You've got obesity, intellectual disability, and an insatiable appetite. It's like someone cranked up the hunger dial to 11 and broke off the knob. But here's a crash course tip. Remember, PPW, Prader-Willi patients are plump and weak.
That's a great mnemonic, Crash. Now let's talk about the ethical implications of genetic testing for these disorders. It's crucial for future doctors to understand the moral and legal aspects of genetic counseling.
Absolutely, Pete. Genetic testing is a double-edged sword. On one hand, it can provide valuable information for family planning and early intervention. On the other, it raises questions about privacy, discrimination, and the psychological impact of knowing one's genetic predisposition to certain conditions.
Excellent point, Crash. Doctors need to be aware of the potential for genetic discrimination in employment and insurance. The Genetic Information Non-Discrimination Act, GINA, of 2008, provides some protections, but it's not comprehensive. It's our responsibility to ensure patients understand the implications of genetic testing before they consent.
You're right on target, Pete. And speaking of hitting targets, did I ever tell you about the time Marcus Cooper and I went bow hunting? This guy was so smart. He calculated the exact trajectory of his arrow, accounting for wind speed, humidity, and the curvature of the earth. hit a bullseye from 500 yards away.
Crash, I think your Marcus Cooper stories are getting more far-fetched each time. Let's get back on track. We need to discuss single-gene inheritance disorders. These are divided into autosomal dominant, autosomal recessive, and X-linked disorders.
Right you are, Pete. Let's start with autosomal dominant disorders. These are the attention seekers of the genetic world. One affected allele is enough to cause the disease. Key examples include Huntington's disease, Marfan syndrome, and familial hypercholesterolemia.
Good examples, Crash. It's crucial to understand inheritance patterns in penetrance. For instance, Huntington's disease shows complete penetrance, meaning if you have the gene, you'll develop the disease. Marfan syndrome, on the other hand, has variable expressivity, so the severity can differ even within the same family.
Exactly, Pete. Now let's hit our listeners with another practice question to keep them on their toes. You ready for this one?
Fire away, Crash.
All right, future doctors. A 45-year-old man presents with progressive involuntary movements and cognitive decline. His father had similar symptoms in his 50s. Genetic testing reveals an expanded CAG repeat in the Huntington gene. What is the inheritance pattern of this disorder?
Great question, Crash. Let's break it down for our listeners. The options are A, autosomal dominant, B, autosomal recessive, C, X-linked dominant, D, X-linked recessive, or E, mitochondrial inheritance.
Take a moment to think about it, folks. Remember the clues in the question. The father had similar symptoms, and we're dealing with the Huntington gene. The answer is A, autosomal dominant. Huntington's disease is the classic example of an autosomal dominant disorder.
Spot on, Crash. Now let's move on to autosomal recessive disorders. These require two affected alleles to cause the disease. Key examples include cystic fibrosis, sickle cell anemia, and phenylketonuria.
Right, Pete. And here's where carrier frequency becomes crucial. For instance, if both parents are carriers of cystic fibrosis, there's a 25% chance their child will have the disease. It's like rolling snake eyes. Not common, but certainly possible.
Great analogy, Crash. Now let's tackle X-linked disorders. These include Duchenne muscular dystrophy, hemophilia A, and G6PD deficiency. It's crucial to understand the differences between X-linked dominant and recessive inheritance.
Absolutely, Pete. In X-linked recessive disorders like hemophilia A, males are more commonly affected, while females are typically carriers. It's like a genetic game of hot potato, and the guys usually end up holding it.
That's one way to put it, Crash. Now, let's shift gears to multifactorial inheritance. These disorders result from a combination of genetic and environmental factors. Examples include diabetes mellitus, hypertension, and schizophrenia.
The nature versus nurture debate in action. It's crucial to understand the interplay between genetic predisposition and environmental triggers in these conditions. It's like having a bow and arrow. Your genes are the bow, but the environment pulls the string.
Nice analogy, Crash. Now let's discuss polygenic inheritance, which involves multiple genes contributing to a single trait. Height and intelligence are classic examples. It's important to differentiate between polygenic and multifactorial inheritance.
Right you are, Pete. Polygenic traits have a continuous distribution in the population, while multifactorial disorders often show a threshold effect. It's like the difference between a bullseye target and a pass-fail test.
Excellent explanation, Crash. Now let's move on to congenital malformations. We'll focus on neural tube defects, cardiac malformations, and gastrointestinal malformations. Neural tube defects include spina bifida and anencephaly.
And don't forget the crucial role of folic acid in preventing these defects, Pete. It's like putting a helmet on your DNA. Adequate folic acid intake before and during early pregnancy significantly reduces the risk of neural tube defects.
Great point, Crash. Now let's tackle cardiac malformations. We'll cover tetralogy of Fallot, ventricular septal defect, VSD, and atrial septal defect, ASD. Tetralogy of Fallot is the most common cyanotic congenital heart defect.
The famous foursome of the heart. Tetralogy of Fallot has four key features: VSD, pulmonary stenosis, right ventricular hypertrophy, and an overriding aorta. It's like the Mount Rushmore of cardiac defects.
That's a memorable way to put it, Crash. Now let's discuss gastrointestinal malformations. These included cleft lip and palate, tracheoesophageal fistula, and Hirschsprung's disease. Understanding the embryological origins of these defects is crucial.
You bet, Pete. For instance, cleft lip and palate result from incomplete fusion of the maxillary and median nasal processes during embryonic development. It's like a construction project where the workers forgot to finish the roof.
That's one way to visualize it, crash. Now let's move on to developmental abnormalities, including teratogens, disorders of sexual development, and inborn errors of metabolism. Teratogens are environmental agents that can cause birth defects.
Right, Pete. Key examples include alcohol, leading to fetal alcohol syndrome, thalidomide, and torch infections. It's crucial to know the critical periods of exposure and associated defects. For instance, alcohol exposure can lead to characteristic facial features, growth deficiency, and central nervous system problems.
Excellent point, Crash. Now, let's discuss disorders of sexual development. These include Klinefelter syndrome, 47XXY, Turner syndrome, 45X, and androgen insensitivity syndrome. Understanding the genetic basis and clinical features of each disorder is crucial.
Absolutely, Pete. Klinefelter syndrome is characterized by tall stature, gynecomastia, and infertility, while Turner syndrome presents with short stature and ovarian dysgenesis. It's like a genetic roller coaster of hormones and development.
That's one way to put it, Crash. Now, let's wrap up with inborn errors of metabolism. These are genetic disorders that disrupt normal metabolic processes. Examples include phenylketonuria, galactosemia, and glycogen storage diseases.
Right, Pete. It's crucial to know the biochemical defects and clinical presentations. For instance, phenylketonuria is caused by a deficiency in phenylalanine hydroxylase, leading to intellectual disability if left untreated. It's like having a factory with a broken assembly line. Things start piling up where they shouldn't.
Great analogy, Crash. Now let's hit our listeners with one final practice question before we wrap up. Are you ready?
Ready as a bow at full draw, Pete. Let's do this.
All right, here we go. A newborn baby girl is noted to have ambiguous genitalia. Genetic testing reveals a 46XY karyotype. Further testing shows normal testosterone production but lack of response in target tissues. What is the most likely diagnosis?
Okay, future doctors, think about this one carefully. Is it A, Klinefelter syndrome, B, Turner syndrome, C, congenital adrenal hyperplasia, D, 5-alpha reductase deficiency, or E, complete androgen insensitivity syndrome?
Take a moment to consider the clues in the question. We have a 46XY karyotype, normal testosterone production, but lack of response in target tissues. The answer is E, complete androgen insensitivity syndrome.
Bullseye, Pete. In complete androgen insensitivity syndrome, we have genetic males, 46XY, who appear phenotypically female due to a complete lack of androgen receptor function. It's like having a TV remote, but no TV, the signal's there, but nothing's receiving it.
Excellent explanation, Crash. As we wrap up this Uber School production on genetic and developmental pathology, remember to focus on high-yield concepts like common chromosomal disorders, inheritance patterns, and critical congenital malformations.
Absolutely, Pete. And don't forget the ethical implications we discussed earlier. Understanding the underlying mechanisms, clinical presentations, and ethical considerations of these disorders will be crucial for your USMLE Step 1 success.
Couldn't have said it better myself, Crash. To all our listeners, keep studying hard, and remember, every Uber School student passes the test. We believe in you.
That's right, folks. You're all aiming for that perfect score, and with Uber School, you've got the best bow in the business. Now go out there and hit that USMLE bullseye.